Tushar bhai, you can start your talk just after 10 seconds.
Assalamu alaikum and good evening, dear physicians. Today we have 54th session of our lecture series organized by ECG study group. Basically, today we have two sections. The first first portion was scheduled to be presented by Professor Rafique Ahmed sir, and presented by Professor. But unfortunately, Professor M. COVID positive today. And from the ECG study group and from the participants, we wish his early recovery. So, Rafique Ahmed's session, I'd like to request Professor Abdul Chowdhury sir to say some word regarding our dear Rafique Ahmed sir. Wadud sir.
Well, Wadud sir is not here right now.
Some.
He'll join again.
Maybe. Sir, I request Professor M.G. Azam sir to take the honor and say some words regarding our Rafique Ahmed sir, and then we proceed. Azam sir.
Thank you, Tushar. It's my honor and privilege to be here with you to introduce Professor Rafique Ahmed sir. He is not only in Bangladesh, but also the all over the universe and in outside the Bangladesh, equally renowned. And he is the founder of EP Electrophysiology department in Bangladesh. He has enormous contribution to development of interventional cardiology as well as electrophysiology in Bangladesh, not only government sector as well as in private sector as well. And he always tried to bring the intellectual guys, especially who try to contribute in the interventional cardiology or electrophysiology in Bangladesh. He always admire our young generation and try to introduce any our fellows, not all of the forum. So we really grateful to him, and we believe he will be with us as before he was with us, and he will be with us. So this is my privilege to introduce him. Rafique Ahmed sir. Sir, can you please continue your session, sir?
Yeah. Thank you. Assalamu alaikum. Azam, thank you very much for the kind introduction. Today's session was supposed to be two-part. One was Dr. Professor Atahar Ali talking about the anatomy and physiology. I thought that will be first and then followed by me. Tushar requested me to do this. This is a little bit academic, but understanding ladder diagram actually helps understanding cardiac arrhythmia and ECG, mainly cardiac arrhythmia. When I trained in Japan, my professor taught me something that whatever ECG we saw, he wanted us to draw it. And his concept was, if I can draw the ECG, then I understand it. So this is what it is. A little careful attention to this. I'm going to look at this ECG. Now, this is the P wave, then isoelectric line, QRS complex, ST segment, and T wave. So normally when we think of P wave, we think of the P wave as a whole, and then we think of AV conduction because it's isoelectric. It's a little different. If you look at here, you see that sinus rhythm originates earlier than the P wave that we can see in the ECG. This is the top line, is the action potential of the sinus node, and it starts a little bit before the surface ECG. That is the time needed by the electricity to exit the sinus node. And then as soon as it comes into the atrium, we start seeing the beginning of the P wave. As the P wave is developing, by that time, AV conduction has already started as dotted by the yellow line. And as the AV node is conducting, simultaneously, the atrium is getting activated. And then you see the isoelectric line. That's when it is now in the AV node only, and then goes to his bundle branch and the his Purkinje. And as soon as it hits the ventricular myocardium, we get the QRS complex. So this is your concept. I'm going to bring this ECG again. As you can see, this is the isoelectric line. This is the time needed by the electricity to come out of the sinus node into the atrium. And then we start the P wave. As the P wave is forming because atrial activation, the AV conduction has started already. And then the his bundle conduction, bundle branch conduction, Purkinje fiber. On the surface ECG, there is no way of distinguishing which part is what. But normally, the time from here to here is about 55 milliseconds. That means a little bit over 1.5 small box, and then the QRS complex. So let's look at it this way. This is the sinus node, and the impulse is generated here. So if I do a ladder diagram, I can have multi-stage ladder diagram. So please bear with me. And if you have any question, I can always go back. Anybody can interrupt me. So the signal starts in the sinus node, and then it then conducts. It takes about 20 milliseconds or less for this impulse to come out of the sinus node. And then from here, it goes into the AV node. It starts the conduction in the AV node. And then from there, it continues on the AV node. The atrial, this is the atrial tissue. By the time atrium contracts here, it goes through the AV node. And please remember that while the AV conduction is going on, the atrium is also being activated. And then we have conduction through the his Purkinje, his bundle branch and the Purkinje system. And then it comes to the ventricle. So this is a ladder diagram. I mean, you don't have to remember, but it's simple. We can do multi-level, or we can make it simpler. We can make it like this. So this is the commonest way it is represented. So we can put atrial, AV node, and his bundle together, and the ventricle. So if I put it simple way, so this is the atrial activation, A, and then it comes very fast, and then it goes through the AV node with the delay, that's the AV delay, and in the V. So that's how a ladder diagram would be drawn most of the cases. And then second complex. So how about this one? So if I look at this one, this is the P wave. So atrial activation, there is AV conduction, and then ventricular activation. And there's a little prolongation of the PR interval. Again, atrial activation, little prolongation, and then this bit, there is atrial activation, and then in AV node, it blocks. So there is no QRS complex. So this ladder diagram shows actually what's happening in the system. So it gives us a little bit better understanding. And then, of course, this one comes up and AV node, and then you can keep drawing it. So what is the good part about drawing it and understanding, and I sometimes will draw it, it gives me a real good concept. And we start with simple ladder diagram. And this is one of the simplest, a sinus node and the AV conduction. What happens in this one? Here, I have the P wave, atrial activation, AV conduction, and then V. The next P wave doesn't go. So A, and then it blocks in that. I'm making an assumption where it is blocking, because unless we have intracardiac, we cannot tell if the block is in the AV node or in the below the his bundle or inside the his bundle. But it's just a concept. So 2-to-1 AV block, one atrium conducted, next one blocked, next one conducted, next one blocked. So, and so on and so forth. So this is a simple way. So let's look at something else. This is a case where you can see in the beginning, it's a little difficult to see, but if you look at lead 2, you can see there is 2-to-1 flutter, and it's very, very clear over here that there is flutter wave. Here I'm imagining 2-to-1 flutter, but over here the flutter wave because the conduction is a little better. Let's make a ladder diagram of this one. So if I take this signal, which is a P wave, whatever it is, it conducts through the atrium, AV node, and into the ventricle. And then at the same time, it goes back, a re-entry circuit in the atrium, and then produces another re-entry. And while this one doesn't conduct, it blocks here because there is no QRS complex. And this one goes back. This is a second flutter wave now forming. And this conducts and then forms the flutter wave. So we can now keep doing it. So this one, again, it goes back, produces the flutter wave, and then it comes down, it blocks. The next flutter wave blocks. Next one conducts with a little bit longer AV delay here. So, and then there is a flutter wave over here, which doesn't conduct. This one conducts with a little long AV delay, and then it can continue. So this is a typical atrial flutter. So what I'm showing in this ladder diagram, that there is block in the AV node intermittently, and then the re-entry is in the atrium. So this ladder diagram, if I look at just this ladder diagram, I'll be able to tell the re-entry circuit is in the atrium. How about this tachycardia? This is if you look at this, is a narrow QRS tachycardia at a rate of 130. I've shown this before. And if I look at lead 2, there is something here. It can be part of QRS complex, but however, when the patient is in sinus rhythm, there is no such thing. So that means this is a retrograde P wave. So I'm making an assumption that there is a narrow QRS tachycardia with a P wave immediately after the QRS complex, and most likely mechanism is evinodal reentient tachycardia. What's happening? That this is the P wave. So electricity goes down the slow pathway and comes back. So this P wave conducts through the slow pathway, produces the QRS complex, and at the same time produces the P wave, which is a fast conduction. That's why it comes closer. So this is typical slow, fast evinodal reentient tachycardia. Now let's draw a ladder diagram of this one. So I'm starting with this P wave. This is atrial activation, and this conducts through the AV node, taking a longer time, and then it goes down the His-Purkinje system, at the same time starts going back through the AV node, the fast pathway. And then, of course, it goes back into the atrium, producing the P wave, because this is going through the fast, but this is coming down the slow pathway. It takes longer time, fast pathway, faster time, shorter time, and at the same time conducts into the ventricle. Please look at this. So this now re-entry. So I have now, again, going down the slow pathway, coming back to the fast pathway. And so it gives it. So what I can see here, that the re-entry actually is in the AV node. And this can continue without the A or without the V. And as a matter of fact, sometimes you can see a 2-to-1 AV block with AV node re-entry. As this AV node is not part of the ventricle, ventricle is not part of the circuit, even if I don't have participation of the ventricle, this will continue with this tachycardia. So this is typical AV nodal reentient tachycardia. I think this lecture is going to be short because I thought it was part of the 2-part series, but we can take it. So this is another patient. As you can see, this is, I will take lead 2. There is delta wave. So this is a patient with WPW syndrome, and we induce tachycardia. And this lead 2 is a little difficult to see, but there is a subtle notch in the T wave, and it's a long, RP is shorter than PR, short RP tachycardia, but it's outside, it's atrioventricular reentry. What's happening here? This is the same patient intracardiac signal. As you can see, this is the QRS complex, and this is a P wave, this P wave is earliest in the CS4 distal. That means it's the left-sided accessory pathway. So what's happening? This electricity is this one. If I take this signal is coming down through the AV node and going down, conducting the ventricle, and then comes back. So from here, this is the ventricle, and then it comes back to the atrium. And that's why the RP is longer than AV node re-entry. So how do I draw this in a ladder diagram? So I'm going to take this P wave where I marked it. It goes through the AV node, then goes through the Purkinje system. As you can see, I have made the slope a little different. That means AV node conduction is slower than his Purkinje. His Purkinje conduction is very fast, and then it goes into the ventricle. And as it reaches the ventricle, it bypasses the AV node, his Purkinje system and everything, and comes back into the atrium. And then we have another one. Then it goes down through the AV node, again conducts the ventricle, and again it goes. So, and the whole tachycardia. And as you can see, this is now a re-entry which involves everything. That means it involves the atrium, it involves the AV node, his Purkinje, ventricle. So this tachycardia cannot continue in the absence of any of this circuit. And during electrophysiology, we normally try to prove that this is a circuit involving all of them. So this is a ladder diagram with typical, I would say, avinodal reentrant tachycardia, atrioventricular reentrant tachycardia. I think, unfortunately, I thought that this is a topic that I'm not going to go too much on it, but give you all the basic concept of that. So I will leave it here, and if anybody has any question, I'll go over it. Or the panelists, if you have any discussion on this issue. Everybody is quiet. Tushar? Could you all hear me?
মহসিন, তুমি ইয়ে করবা? হ্যালো,
Wadud.
আমরা এখানে নেটওয়ার্কের সাংঘাতিক ঝামেলা করছি স্যার, আমি পুরো ইউ করতে পারছি না।
তাই মনে হচ্ছে আর কি, যে সবাই কোয়াইট তো দেখছেন।
তবে এইটা স্যার, এই লেটার ডায়াগ্রামটা আপনি আজকে দেখে খুব ভালো করছেন স্যার, কারণ এই জিনিসটা আমাদেরও মাঝে মাঝে কনফিউজড লাগে, বিশেষ করে ওই যে এই ইয়েটা যেটা হয় WWD ক্ষেত্রে যেটা হয়, কনফিউজিং হয়ে যায় তখন। এই জন্যই বোধহয় স্যার ওই WWD ইয়েতে ইন্টারাপ্ট করলে চট করে হয়ে যায়, এভিনোডাল রিয়েন্টেড গুলো আপনার চট করে ইন্টারাপ্ট করা যায়, কিন্তু এট্রিয়াল ট্যাকিকার্ডিয়া বা ওগুলাকে ইন্টারাপ্ট করা খুব ডিফিকাল্ট হয়।
Yes, because atrial tachycardia does not have, it can be re-entry, but most of the time it is avinodal re-entry. Automatic focus atrial tachycardia.
Actually.
Yeah. So I mean, the purpose of the ladder diagram is basically to give the concept of that how to draw it, and drawing it helps because then you understand it better.
Sir,
I don't have any.
Ajam, can you respond?
Sir, আমি ওই ইয়ে করছি স্যার, ওই যে I just give in chat box to raise any question from the audience so that we can bring it here for the more discussion. Any sir, our MD student are already joining in this program. Abdul Mamun. Ribu.
Yes, sir.
Can you hear me?
ওদিকে বলা হয় হ্যান্ড রেজ করতে if they want to put a question.
হ্যাঁ আমি ওইটা স্যার ওইটা বলেছি।
স্যার আব্দুল্লাহ মামুনকে কি ই করব?
একটু ব্রিং নিয়ে আসো, একটু কোশ্চেনটা শুনিয়ে।
ওকে ওকে।
Tell him to raise the hand so that we can pick him up, and
it will be easier sir to identify.
Wadud.
হ্যাঁ।
তুমি কি so I mean asking
Sir, give us a minute. He has raised his
আমি
hand.
রাস্তার মধ্যে
Make
আটকা
our
পড়ে
answer panelist. 1 minute, sir.
লাস্ট হাফ এন আওয়ার আমি আসলে রাস্তার মধ্যে আটকা পড়ে আছি।
oh আচ্ছা আচ্ছা আচ্ছা
আমাদের স্যার কি রাস্তায় বাইরে বোধ হয় নাকি স্যার?
হ্যাঁ, দ্যাটস দ্য
ও।
প্রবলেম।
আচ্ছা, এই জন্যই আমি বুঝতে পারতেছিলাম না। আচ্ছা ঠিক আছে স্যার।
আমি একদমই ঢুকতে করতে পারলাম না, সময়টাই করতে পারলাম না। কখনো এরকম হয় না, কিন্তু আজকে ওই রোটার ওই সেশনের পরে সবকিছু মিলে লেগে গেছে। ইট ওয়াজ টু লং। উই হ্যাভ অ্যানাদার সেশন স্যার, ওই লাইভ সেশন অফ রোটাবলেশন, ফজিলা ভাইয়ের শুনলে ক্রিটিক্যাল কেস, and then about theoretical discussion. That was a very good session, but that was very long.
no of course
We were in the Heart Foundation, and from there I have to give a round and then come back. Now stuck in the
তুমি ঢুকো না কেন? কোশ্চেন করো।
so we don't have any
Tushar, where are you?
আব্দুল্লাহ মামুনকে ইনক্লুড করো। হ্যাঁ
Sir, somebody question, is the letter diagram stops at ventricle?
oh no, not necessarily. I mean the normal, okay, I'm going to come back. It's a representation like this one. If you look at it, it's a normal rhythm, so it stops at the ventricle. However, if the ventricle is the end of the circuit, however, except if there is any reentrant tachycardia using that accessory pathway, then it continues into the accessory pathway. So that's how it is. Ladder diagram represents the pathway of the electricity. Any other question?
Sir, can the ladder diagram help us in differentiating? Sometimes we find it very difficult to differentiate between atrial tachycardia and atrial flutter. Which one is which? Can it help us in doing that?
No, because ladder diagram is representation of what I am thinking.
Yeah.
It is not the answer for the problem. So a ladder diagram is good to, so it may be possible that when I'm drawing a ladder diagram, I may understand the arrhythmia a little bit more, but it's not giving me any answer. It is just a representation, how to explain what I'm telling you. So that is the whole purpose of it, and understanding the level of electric conduction.
Which way the pathway is going actually?
Exactly. Exactly. So let me do this. I don't know if I have any questions today, but
Sir, Assalamu alaikum, sir.
understand?
I'm Dr. Abdul. I have a question, sir.
Sure.
Sir, sir, I want to know any rule of ladder diagram in therapeutic purpose. Is there any rule in therapeutic?
No. As I am telling you,
or decision making process?
Not at all. Not at all. It is an academic discussion, and academic. If let's say I'm telling you that this is how it is working, and I'm just drawing it in line for you to understand it better. But this is not an academic thing. Sorry, this is not a therapeutic thing. You cannot use it for that. It will be only for explaining the arrhythmia mechanism. And for us, like this, what I did, I drew all this ladder diagram that you saw. It's not from the book. I draw it. And when I drew it, I knew exactly what I'm thinking about. And of course, my thinking process can be wrong, but that's what it is. The whole purpose is.
Sir.
Yes.
Sir, ladder diagram is give us a visual impression to make the understanding what is happening in the heart.
Exactly.
The mechanism of arrhythmia.
And mechanism, yes.
Sir, I would say the mechanism of arrhythmia, why this arrhythmia is occurring. it gives us some clue about that.
Yes, that's true. That's true. So what's your
Sir,
sorry.
one question, sir. One question from Lieutenant Colonel Nizamul Hussain.
Yes.
If it is first flow pathway, what will be configuration of the diagram?
Oh, it will change. If it is a fast flow, it will change. Usually the fast flow is not common. Is about 10%. So the diagram is going to change. So basically you are going down the fast pathway, coming back to the slow pathway. And that will give us a reverse. The P wave will be, it will be a long RP tachycardia. Yes, it's going to reverse.
Sir, please continue your delivery. Rafique sir, you are requested to go your delivery because no more discussion. Someone requested, so I think you should continue for next season, sir.
No, I did not continue. I didn't, unfortunately, because I thought that this will be, Atahar will be doing half of it. So I did not prepare any questions this time.
Can you show any one or two more interesting ECG so that we can just discuss?
Okay, let me see. You have to give me a few seconds. I can pull up some old ECG. I don't like to do it because, sorry about this. A storyteller must have the stories right.
Very true. Very true. Today, actually, sir, we are in a very desperate situation, and we are very shocked, actually.
Yeah, I know. I wish I had.
The news came rather suddenly.
Yes.
Let
Let me see. I mean, I think it'll be good to look up. I'm going to, if you don't mind, we can look up some of the old ECGs, and everything helps.
Yes, sir. Sir, that will be better.
Give me 1 second. We may be able to. I may be able to.
It's all right.
Okay, so we'll do something. So we can actually do some questions and we can do some poll. All right, so let's do this. Can you see it?
Yes, sir.
Okay, so we'll do questions. Okay, so this is the ECG, and we have the Wadud. Are you with me? With us?
Yes, sir. Oh, from the very beginning.
Okay. Wadud, you want to take this? So majority said sinus rhythm, normal ECG. Some 40% said sinus rhythm left axis, and few people said left anterofascicular block.
The thing is, when you look at the ECG, just consider that whether it is a sinus rhythm, yes, there is P wave, and it's a sinus P wave, it is uptrend in 2-3 AVF. So before the Qrs complex it's there, so it's sinus rhythm. That's quite all right. The second thing is there left axis deviation? If it is so, if it is left axis deviation, then the lead 2, which is looking down, the QRS complex should be the other way around. It should be negative QRS complex mostly in lead 2. It's not there. It's positive. It's going down and towards lead 2. That means in normal way. So there is no left axis deviation. Very simple. The third is left anterior fascicular block. We usually call it when we find there is there is axis deviation without any left ventricular enlargement. Then we call it is very likely left fascicular block. That's also axis deviation is not there, so left anterior fascicular block is not there. Then the third is left atrial enlargement. Is it there? Look at the P wave at lead 2. It's not wide. Look at the P wave in V1. The negative component should be at least 1 millimeter wide, and depth should be a sub. But it's looking like a very normal biphasic P wave. So that's also excess diagnosis. So we come back to the sinus rhythm normalcy.
Yeah. So, Ahmed, thank you very much. I mean, nobody answered number 4, which is great. And rest of them, let's look at it. These are basic stuff. Why sinus rhythm? If you look at lead, I put all the ECGs in this grid. Lead V1, biphasic, because it activates the right atrium and left atrium becomes negative and then positive on the other side. And lead 1, AVL are positive. And then if you look at the QRS axis, if you lead 2, lead 1 is positive. That means it's on the right side. And then lead 2 is positive. That means it is between 0 and 30 degrees. And it is more positive than negative, as Professor Wadud mentioned. That means it is more towards 0. So it's not really left axis at all. Sometimes, if it doesn't fulfill the criteria for left anterior fascicular block, but it is like 30 to 45 degree, but we don't think it's left, then we call it left axis. So it is not left axis. So this is basically a normal ECG. How about this one? Let's give a few seconds and let them. Please try to answer as many of you can, because these are something that we have done before. These are the fundamentals. And if you do this, we feel better because we know that we are accomplishing something. Right, Wadud?
Yes, sir.
Yeah.
I think I can now join from the laptop. It will be better. It has taken around 1 hour to come back to home.
Mm.
It's horrible. It is a 15 minutes ride actually.
Mm. So we have all answers. You want me to do it, or Wadud, you are going to do it, or?
Sir, let Adam do it, sir.
Or motion there?
Mohsin, we have seen once. Mohsin, what are you?
I think he's doing procedure.
I have joined.
So let's look at it this way. Let's see if I have the, and I'm going to come back to the answers. I have taken this, all the P waves, and put it in where they should be on this slide. And you can see that it's inverted in lead 2, 3 AVF. It is upright in lead AVL, AVR. If it were sinus rhythm, it will be upright in lead AVL, that's right. But it will be moving away from AVR and towards 2, 3 AVF. And these are going to be upright. Lead AVR will be negative. Lead 1, of course, is upright here. Lead 1 is very flat. Let's forget about the lead. So this is not coming from the sinus node. So those two are out. Now the question will be, is it coming from the AV node? Because there is a junctional, let's say AV junction is producing this rhythm and there is antegrade into the V and retrograde into the A. If that was the case, it will be inverted in lead 2, 3 AVF. However, if you look at my arrow here, my pointer here is coming through this AV node, and then it will go towards the left atrium. Then it will be positive in these leads in V4, V5, V6. V1 will be same upright, but V3, V5, V4, V5, V6, they will be positive because it is coming back and going to the left side. It's not true. The only way I can explain this rhythm is if there is a rhythm coming from the left side, which is inferior, moving away from 2, 3 AVF, going this way, that will be negative in this, and it is moving away from V5, V6, V4. And so this ECG is very typical for left atrial rhythm. It's a very common ECG given in exam, inverted in 2, 3 AVF, and the salient feature is inverted in lateral chest lead. So this is a left atrial rhythm without any doubt. Any comment from any of our panelists? Or
this is very important because I have seen many cases like this last 1 year when you made us aware of this thing. And the thing is, these people do not require any interference because it doesn't hamper their normal cardiac activity or anything. I have found this patient totally asymptomatic. Regarding
Arun, how are you doing? Absolutely. So that's more important.
Oh, fine, sir.
Yes, it is a diagnosis, but it has no clinical consequence as it is. So we don't treat this. So let's go to the next one.
Sir, Professor Muskie is here.
Yes, I said.
Oh, hi. Sorry, a little late.
Muskie, you missed the letter diagram explanation.
Yeah, that was I was trying to get, but unfortunately some work could. I'll see in YouTube.
So this one. Okay, good. Very interesting. You want me to talk about it? Or anybody else?
Baski, do you want to talk about it?
Yes.
About the polls and questions.
Yes. I mean, rate is it's
106.
106. So I find the P waves are a little taller here, but there's no mention
Yes.
of that. And
Yeah.
so axis is normal. And then some VPCs here. So we need to mention, I do not find any STT changes in this patient.
Yeah.
And
So, I mean,
Sir, actually,
So
I would say, sir,
Yeah.
here it seems that two answers could be correct.
Yes.
Sinus tachycardia with ventricular premature beat, yes, one premature beat is there. And sinus tachycardia with non-specific 2F changes, that also we may accept.
yes. Okay. So this is the part that you can see my pointer, right? And there is artifact, and this looks like a wide beat. But the timing of the wide beat is not early. But if we look at the rhythm strip below, simultaneous, perfectly normal QRS. And the reason I brought it up, I mean, look at this here, is perfect, nice. So this, even though it looks like a PVC, it's actually sinus tachycardia. With no, I mean, put the non-specific term. As Arun mentioned, there is a little bit tall P wave here. I did not put it part of it. So even though it looked like premature beat, but in the rhythm strip, it is not. So please always watch out this kind of things. That if we find a 3 premature beat artifact like this, they almost can look like VT, even though they are not. So this is not uncommon. It's just a ECG artifact, and I just wanted you to be aware of it. I mean, of course, clinically, if you answer sinus PVC, nobody will blame you because you are not hurting the patient by making these diagnoses, because that one PVC is not going to make any difference in the clinical management of the patient. We can give the poll.
And all your patients are 70 plus.
Oh, yes, yes. Well, now 70 looks like young to me. When I get 70-year-old, I mean, I have patients like 94, 95, they walk into the clinic. I mean, it's amazing. But interesting part, all the people that are over 85, none of them are obese. So that's a very common pattern in it. Okay. Okay. Whoever answered E, there is no E here, number 5. But anyway, I'm going to talk about it. First of all, sinus rhythm with sinus arrhythmia. To call it, I understand why the question of sinus arrhythmia comes up, because there may be a pattern. You can see my rhythm strip that there is some group beating. However, there is no P wave anywhere. If you look in the rhythm state, if you look at lead, this bit may look like P wave, but it's not. You look at this wiggly line in lead V2. It's very typical for fibrillation. So second diagnosis, atrial fibrillation, slow ventricular response, that's the correct diagnosis. But I also put 4-hour progression for V1 through V5. That probably fits in. So both are correct. This is probably 3 is more appropriate. Now the atrial flutter with slow ventricular, there is no flutter wave. Now you can say this is flutter, but this is basically what we call coarse atrial. To be flutter, you have to see the typical flutter wave. So this is not even the group that we call flutter fib. This is basically atrial fibrillation with slow ventricular response. We have to define this 4-hour progression from V1 to N. What does it mean? You can look up in the book. It can be many things. It can be anti-MI. It can be poor lead position. We can see that in patients with COPD or left ventricular hypertrophy, or even rotation of the heart can cause 4-hour progression. And other thing that happens a lot of times in females, you see, this is a female patient that because of the breast tissue, they don't put the ECG in the right place. And in females, you'll see more 4-hour progression than in males because it's put in the wrong place. Anybody, any other comment or Wadud?
So this is very important in the sense, sometimes when the rhythm is almost near normal, people become confused whether they see atrial fibrillation or normal rhythm, etc. But when we want to see the rhythm, atrial rhythm, we have to pay more attention to the lead 2 or a FEF or V1. We have to pay attention to these, because only then we can see clearly whether there is any atrial activity or not. That's very important.
All right. Go to the next one.
Somebody is asking why is atrial fibrillation not flutter? The one who is questioning, please see the next ECG is showing and
So this
understand
one,
the difference.
okay, I'll tell you, you may call this flutter, but it looks like, what is the difference between a horse and the donkey or a horse and the giraffe? Both has 4 legs and everything, but they look different. This looks like flutter wave, but it is not flutter. This is coarse atrial fibrillation. And now let's look at this one. What do you think of this one?
সেটা ছেড়ে গিজারটা ছেড়ে দিস ভিতরে আবার কিছু পড়ে আছিস হ্যাঁ
As Rafique sir used to say, we have to memorize the pattern of picture for a particular rhythm. If it is ingrained in your memory, you will always jump to that initial diagnosis and then analyze it to decide whether your initial decision is correct or not. Look at this pattern and look at the previous pattern, then you will understand what is the difference between the two.
Okay.
That's nice. That's nice.
That's nice, yeah. So nobody said sinus, which is fine. Nobody said ectopy. So between the atrial fibrillation and atrial flutter. The problem with atrial fibrillation part is that it is so regular. With such regularity, it will be almost impossible to call it atrial fibrillation. Only time you will see atrial fibrillation with a regular RR interval will be when they develop complete heart block. And that will be a much slower rate. So if the rate was like 45 or even 50 with fibrillation wave, and we see a regular RR, then we'll call atrial fibrillation. But this is not fibrillation. That's the only time we get it. So this is, and then can we see the flutter wave? In lead 2, if you imagine this flutter wave and this one, then you can see the 2 to 1. Ignore this R wave. If I cover up the R wave, if I cover up with my red dot, you can see the sawtooth appearance. And then I'm going to show you this same patient, little bit, there is a little bit slow response here. You can see, now you can see the flutter wave very clearly. This is typical atrial flutter with initially 2 to 1 and then variable conduction. There is some attempt to slow down. This is typical atrial flutter. Please remember that I think I'm going to skip this one. We have done this kind of ECG before. Okay, we'll do this one, and then after that we should stop, right?
All right, sir.
Yes.
But what I find, sir, discussing going back to the same ECG again and again actually helps.
It does. It does.
It helps.
Okay. Wadud, this is yours.
Whenever, what I say to my students, whenever you look at ECG, look at lead one. And before deciding to proceed to interpret the whole ECG, have a very clear look. The QRS complex is negative. Why should it be? It's supposed to be upright because the current is starting from the right, going to the left, and the left is predominant. So the lead one, which is looking at the heart from the left, should have a very clear-cut upright complexes. It's not there. So how is that possible if the heart is on the other side? Or if I'm putting the limb lead in the other way around? Or if I have lost the muscle totally, that means I have a huge MI. Now, if that is so, now look at the initiator, the P wave. It's negative here. It should not be. If it is negative, I'm going to AVR, but it seems like a little bit positive in there. The reason could be either I have a right-sided heart, dextrocardia, or I have put my limb leads in the other way down. If it is real dextrocardia, then the QRS complexes should be tall QRS complexes on the right-sided lead V1, V2, gradually becoming smaller in V5, V6. It is not so. It looks like very normal QRS complex starting from V1 is smaller, then gradually getting bigger and quite big in V5, V6. So the heart is on the left side quite all right. And this is a limb lead displacement. And left-right transposition of leads.
Yes, so thank you. I mean, you put it very nicely. I mean, this is a very classic picture of limb lead displacement. And then you, first of all, you look at it. If you look at something, first think of limb lead displacement, and then you reason it. If with the same is QRS, the P wave was upright, as Wadud mentioned, I'd have said maybe there is a lateral myocardial infarction. If there is lateral myocardial infarction, that should have been reflected in V6 also, which it didn't. So this is the multitude. Now it could be an ectopic atrial rhythm. Now, if it were because if there is a left atrial rhythm from the top, AVL will be negative, 1 will be negative. However, QRS will be upright. It's not. So only thing that is, so when you report this ECG, first of all, I will write suspect arm lead reversal. And then interpretation assumes no misplacement. And I will report the ECG, and then I will say repeat the ECG again. And then this is the repeat the ECG of the same patient. So January 7, this was, what date is it? October, later on ECG, look at the regular ECG of the same patient, it's perfectly normal. So it's a limb lead misplacement from the same patient. I think we're going to stop here, and if there's any other questions, we'll take it.
Sir, I think one of the important thing is when there is misplaced upper limb, lower limb leads, there's complex ECG changes in there. Those are the things that make people confused. My rule of thumb is if there is a pattern which does not match anything, I always ask that please repeat the ECG.
Yeah. Let's do two more and then we'll stop. Let's do this one. When you do multiple choice questions, there are certain things that you can use trick. And I'm going to give you the trick in this case. Look at the heart rate. So that will immediately exclude the first two. So I'm giving away the answer. So that's immediately, so still people answered sinus rhythm, left atrial arrangement. Basically, let's redo the poll again. I'm going to give you the hint of doing multiple choice questions. So we're going to redo the poll. For the audience, remember, the heart rate is 111. So if you use simple thing about answering question, it is a tachycardia. So first two choices are null and void because first two choice is not tachycardia. So let's do it again. So let's see if we can get a better answer now. Let's do the poll again.
Redo the poll.
So when there is a trick of doing multiple choice questions that you have to read the question properly. You also have to quickly go through the list and to see if you can exclude some of the diagnoses because they are definitely wrong. And in this case, as the heart rate is 111, it is a tachycardia, not regular sinus rhythm. Of course, it is sinus rhythm, but it is sinus tachycardia. Okay. Still, I have one answer, a sinus tachycardia, probably didn't know. So yes, this is better. So the question is, this is Arun or Wadud's question, actually.
Arun,
So,
can you talk about it?
Yeah, I mean, as Rafique sir has said, there's a heart rate around 111, so that virtually exclude two. Then the tachycardia is there. So if you look at this lead 2, there's a tall P wave, and if you look at the lead V1, so negative deflections are more. So this indicates there's a biatrial enlargement.
perfect, beautiful. I mean, this is typical, right? It could be, this can be given in an exam, and anybody not answering it correctly cannot complain. This is a very typical biatrial enlargement ECG, right? Although do you agree with that?
Yes, yes, sir.
Yes. So, I mean, for the audience, I mean, when we in exams, we try not to give questions which are too controversial. I mean, some teachers do that, but here in America, we don't. We always give ECGs that are clear cut, like this ECG will be given in an exam for biatrial enlargement. Thank you. Then we'll do one more and then done.
Okay, sir.
This one. Heart rate is 168.
Yeah.
We have all answers. Okay. I will start with the tachycardia. This is the tachycardia 168, and it's a white QRS tachycardia. So first thing I think of white QRS tachycardia is VT unless proven otherwise. So if it were atrial flutter with 2-to-1 conversion, that flutter is a very fast flutter. 168 times 2 is basically 340. Most flutters are 300 beats per minute or around that number. And secondly, I cannot see any flutter wave. Supraventricular tachycardia with right bundle, yes, it's a possibility. Sinus tachycardia, old inferior and lateral myocardial infarction is a possibility. And the ventricle. So let's look at this, lead V1. If you look at right bundle, initial R is bigger than the second R. That supports VT. So let's see if I have those, this. And then whether there is any P wave or not, it's tough to say, but maybe there is some P wave here. It is very difficult to see. But look at this. This is the patient with after cardioversion. And then we use those algorithms, right bundle, left axis deviation, initial R bigger than the second R, and the R and S ratio in lead V6 is less than 1. That supports VT. So this is actually this is a patient that one of our patients with ventricular tachycardia. And then this patient actually after conversion, you can see this really normal sinus rhythm, same patient. Thank you.
Thank you, sir. You have saved the day.
Thank you.
স্যার আমি একটু ডিসকাস করতে চাচ্ছি একটা পয়েন্ট একটু সরি আমি শফিক ভাই আছে ডক্টর আবু মোহাম্মদ শফিক
Yes, 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 welcome.
হ্যাঁ
স্যার
হ্যাঁ শফিক দেখা যাচ্ছে
last month he presented a case Brugada syndrome with cardiac
স্যার সেই কেসটা স্যার এটা না আর কাহিনী হয়েছে স্যার
this patient এখন আমার ঘরে এসে পড়ছে স্যার
this patient এখন ওর ঘরে
Good.
ওইটা ব্রুগাডা সিনড্রোম যেটা ছিল ট্রপোনিন a bit higher ছিল in heart foundation গেছিল তো they advised for coronary angiogram followed by ICD so আমরা তাকে ICD এর জন্য প্ল্যান করছি that after tomorrow তো আমরা একটা আজকে চেক coronary দেখে নিলাম coronary is okay এখন তাকে আমরা মানে ICD এর জন্য প্ল্যান করছি কিন্তু শফিক ভাই এখন কি অবস্থা কি তার আসলে কি করা উচিত আপনি ফাইনান্সিয়াল কি ব্যাপারে হেল্প করছিলেন
না এটা তো স্যার ম্যানেজ করছিলেন আর
No, I'm out of that loop. That is no, that I am out of that loop. So he is. I offered, they refused, and once that might have a simple theory in life. In good intention, we always do things. If you don't have the generosity to accept offer in the first time,
right,
that is gone. Simple.
Excellent.
So I have no obligation. Amar life, I have some obligation to Allah and the country, and I always do it. And once I offer it, and once somebody refuses it, it's up to him to decide what to do. I'm no longer in it.
খানিকটা স্যার আমার ক্ষেত্রে সেটাই করছে স্যার কারণ আমি যখন তার ভাইকে কমিউনিকেট করলাম কমিউনিকেট করার পর সে খুব হলো না তাকে কেউ রেসপন্ড করে নাই তারপর আমি রিপিটেডলি ফোন করা সত্ত্বেও যখন ফোন ধরছে না তারপরে আই জাস্ট মানে কাট আপ করে দিয়েছি এভরিথিং আমি আর কোনো খবর নেইনি কারণ হচ্ছে আমার কাছে মনে হলো যে যখন আমরা সেদে কোনোটা দিতে চাই তখন কারো ধারণা হয়ে যায় যে এর মধ্যে বোধহয় খারাপ কিছু আছে তারা নিতে একটু কষ্ট হয় আর স্যার সেই জন্য আমি আর কমিউনিকেট করিনি এদের
এখন স্যার রোগীটা হয়েছে কি হার্ট ফাউন্ডেশনে গেছিল ওখান থেকে পরে আমাদের এখানে আসছে আর কি অনেক খরচের কথা বলতে আমি রোগীটা দেখে সিনারিও হিস্ট্রি আর ইসিজি দেখে আমার মনে পড়লো যে এই কেসটা তো আমার কাছে নোন মনে হচ্ছে
জি জি
কিন্তু আমি ওই সেশনটায় ছিলাম। তো এবং টোটাল ইসিজিটাই আমার কাছে মানে ওই ইসিজি তো স্যার লাইক এ হোয়াইট এলিফ্যান্ট, একবার দেখলে তো স্যার ভুল হওয়ার কথা না। ওইটা
না
সাথে সাথে ওইটা আমার মনে পড়ে গেছে যে এই ইসিজিটা তো আমি দেখেছি আগে। আমি তখন জিজ্ঞেস করলাম তুমি কি এখানে ভর্তি ছিলে, তখন সে কাগজ বের করলো, ইউনাইটেড হাসপাতালে কাগজ সব বের করলো। আমি দেখলাম যে ক্লিয়ার কাট সব এখানে ডেসক্রিপশন দেওয়া আছে। তো তাকে বললাম, সে বললো যে তখন আমি রুগীকে বসে তার বলা আছে আইসিডির কথা, সে বলছে কিছুই বলে নাই, সে আমাদের এখানে চিকিৎসা নিতে আসছে। দেখলাম যে একটু হাইড এন্ড সিক করছে। আমি শফিক ভাইকে ফোন দিলাম, শফিক ভাই এই রুগীটা এরকম নাম, এটা আপনার রুগীটা কিনা? তখন উনি বললো যে হ্যাঁ এই রুগীটা। আমি বললাম কি ব্যাপার বলে, তা উনি কথা বললো ওই ভাইটার ব্যাপারে কথাবার্তা বললো, আমার সাথে ওরা ভাইরা দেখা করছে। তো স্যার আমরা আসলে কথা বলছিলাম, কিন্তু ওখানে আমাদের 2,80,000 টাকা খরচ হয়ে গেছে, আমরা ওখান থেকে স্যার এখন চলে আসছি। আমি বললাম যে তোমরা চলে আসছো, তোমরা এত টাকার জিনিস কিভাবে ম্যানেজ করবো? আমি তো না কোম্পানিকে বললে হয়তো কিছু হবে, কিন্তু মিনিমাম তো 3-4 লাখ টাকা লাগবে, এখন কিভাবে ম্যানেজ করবো? তখন ওরা স্যার বলতেছে যে আপনি স্যার অ্যারেঞ্জ করেন, আমরা করবো। আমি চিন্তা করলাম যে স্যার এর পক্ষে তো আসলে বার্ডের, সে একজন ড্রাইভার, তার যে মালিক তাকে দেওয়ার কথা ছিল, মালিক কিন্তু আগায় আসতেছে না।
I know the whole story. Ajam,
হ্যাঁ হ্যাঁ স্যার,
this is a mute discussion. এখানে এটা নিয়ে I thought about it. I had a solution. I gave the solution. Solution was not accepted. So this is a null and void discussion. There's no point of wasting any time. আমার স্যার বলতো একটা কথা, আমরা যখন স্কুলে পড়তাম, তোদের মতো 5টা ছেলে মরে গেলে দেশে কোনো ক্ষতি হবে না, আরো অনেকগুলো ছেলে আছে আমাদের।
এটা ভালো, একদম বাস্তব কথা স্যার।
বুঝছো? So I wanted to help this person. আমি এবং আজিজ মেইনলি স্পিয়ারিট করছেন যে আমরা পুরো টাকাটাই দিব, এবং ওয়াদুদ এখানে রাজি হয়েছিল কন্ট্রিবিউট করার জন্য, but he did not accept it. So that is gone. That is not going to come back. If somebody else wants to come back, fine, but I will not be part of it at all.
না, আমার মনে হচ্ছে এটা উচিত হবে না। এই এত ব্যাপারটা তো আমরা জেনে গেছি স্যার, আর এই কেসটা তো আমাদের জানা।
না না শোনো, এগুলা এটা নিয়ে মানে এগুলো আগেও হয়েছে। কারণ হয়েছে কি, যখন তুমি যেটা হয়, এটা আমাদেরও হয়তো, আমরা যখন এই প্রথমে এই দেশে আসছিলাম, যখন কোনো অফিসে গেলে সহজে কাজ হয়ে যেত, ভাবতাম যে কি ব্যাপার, ঘাপলা কিছু আছে নাকি।
কারেক্ট স্যার, আসলে এবং যেটা হয়েছে স্যার, আমরা খুব বেশি বলছি স্যার, আমরা পেশেন্টকে আগ্রহ করে আনতে চাইছি স্যার, এইটা বোধহয় কাল হয়েছে ওদের জন্য, মানে ওরা হয়তো এটাকে মিসরিড করছে স্যার। কারণ আমি বেশ কয়েকবার ফোন করছি যে তোমাদের জন্য সব অ্যারেঞ্জ করতেছে, আমেরিকা থেকে আপনার স্যার আপনার কথা স্পেসিফিক্যালি বলছি যে স্যার এই প্রেজেন্ট করাতে স্যাররা এটা দেখছে, নিশ্চয়ই আল্লাহ তাআলা এই ব্যবস্থা করে দিয়েছে স্যারদের মাধ্যমে, এইটা আমি তাদেরকে বুঝাইছি। তারপর হঠাৎ করে টেলিফোনটা এসে ধরেন, কি আজব ব্যাপার, টেলিফোন ধরছে না স্যার, এবং ধরেই নেই টেলিফোন, এবং নেভার গিভ মি এ ফিডব্যাক কল।
শফিক ভাই, আমার রংপুরের একটা রুগী বুঝছেন, ওই যে স্কার রিলেটেড ভিটি হচ্ছিল, বারবার 5 বার সিসিইউতে ভিটি হয়েছে আমাদের। তারপরে আমি তাকে ক্যাথলেবে আইসিডি সিআরটি লাগানোর জন্য নিয়ে গেলাম, রিজেকশন পার্সেন্ট তার 30% মাত্র। আমি দেখি যে জাস্ট একটা শর্ট দিয়ে দেখি যে আরসি একদম 99% একটা ব্লক, এবং এই যে হানিকম অ্যাপিয়ারেন্স। আমি চিন্তা করলাম ঠিক আছে এখানে আগে একটু করে দিই স্ট্যান্ডিং করার পর দেখলাম যে মানে টেবিলও আমরা যখন করি তখনই কিন্তু সে ভিটি ছিল, আমরা ডিসি শক দিয়ে তাকে আমরা স্ট্যান্ডিং করলাম, এরপরে দেখি যে সে স্ট্যাবল। চিন্তা করলাম ঠিক আছে কয়েকটা দিন অপেক্ষা করি, 4 সপ্তাহ 6 সপ্তাহ অপেক্ষা করলাম। এর মধ্যে মানে প্রথম 4 দিন ছিল আমাদের হাসপাতালে, তার কোনো রকম ভিটি হয় নাই, কিছু হয় নাই। এর মধ্যে যেদিন ছুটি দিব সেদিন তার কোভিড টেস্ট পজিটিভ আসে, কোভিড পজিটিভ আসলে তাকে ছুটি দিয়ে দিলাম, বললাম যে পরে তুমি 6 সপ্তাহ পরে আইসো, পরে আইসিটা করি। তারপরে যেহেতু সে মানে কোভিডও সিমটম ফ্রি হয়ে গেছে, তারপরে সে 6 সপ্তাহ পর আমার ডাক্তার যখন ফোন দিল, তখন সে আর আমাদের সাথে যোগাযোগ করছে না। তারপরে সে যোগাযোগ করলো কবে 7 মাস পরে, আবার একটা ভিডিও এসে রংপুর মেডিকেল ভিডিওর পরে, তারপরে সে আবার আমাদের এখানে আসছে। তখন বললাম যে এখন এটা তো বোধহয় করতে হবে স্যার, উপায় নেই। তখন সে আবার বললো যে স্যার যে একটু দেখেন এনজিওগ্রাম করে। ওকে যতই বুঝাই সে কিন্তু আর ওই লাইনে যাচ্ছে না। পরে 3 দিন থাকলো, আমরা অ্যামাডেরন দিয়ে তাকে ছেড়ে দিচ্ছি।
সবগুলো ভিটি কি মনোমরফিক?
হ্যালো,
সবগুলো ভিটি কি মনোমরফিক?
হ্যাঁ মনোমরফিক ভিটি।
এই হাফিজ ভাই, হাফিজ ভাই
আমি এস্টিমেট থেকে বেরোলাম।
মানে এই জিনিসটা
এখন হচ্ছে ওর সাথে যেহেতু আমরা যোগাযোগ করছি
I think for the audience, I think our session is over now. We can discontinue, we can talk, right? And then let's close the session so that.
রিভিউ তুমি ইয়েটা বন্ধ করে দাও, আমাদের জাস্ট প্যানেলিস্টটা থাকি।
Thank you all for participation and we'll see you next week.
Okay, sir.